Yes.
Wow.
All right. Hello, everybody. Thank you so much for joining this fabulous film by Shannon Cohn. And if panelists, if you could unmute, that would be great. And then we can introduce ourselves. Thank you, Shannon. We appreciate this film and all you're doing. I'm going to lead with you. If you could introduce yourself to everybody.
Sure. Hi, everyone. I'm Shannon Cohn, and I think I'm actually I'm at the farm, it looks like today. So sorry, I didn't get the memo that I needed to dress up a little bit more. But anyway, happy to be here. Good to see all of you. It's an honor. I'm excited about this panel. I think it's going to be a great one.
Great. Thank you, Shannon, our executive producer. How about Rachael? Can you go next? Dr. Haverland?
Hello, I'm Rachael Haverland. I'm an endometriosis excision surgeon located in Dallas, and I am a part of the PRM group.
Great, thank you.
Happy to be here. Thanks for having me.
Thank you. Okay, Katie, thanks so much for participating in our panel. Can you give a couple sentences about you and all the great work you're doing?
Thank you. You're very kind. I'm Katie. I am a board certified patient advocate, endometriosis patient, and I currently run a social media platform called Endo Girls Blog. Sorry. And I've been, so I've been in the community for a while now, and I'm just very grateful to be here. Thank you.
Great. Thanks for joining us. Diana, thanks so much for joining. How are you?
So nice to be here. Thank you. I'm Diana Falzone. I have endometriosis. I was diagnosed later in life in 2016 at 32. I was with infertility as well. I'm an EndoFound ambassador, and I run an Endo TV. I'm the executive producer and host of that. And it's an arm of EndoFound to raise awareness about the disease and to talk to physicians, talk to patient advocates, and just try to keep shedding light on this insidious disease.
Great. Thank you, Diana. And Dr. McHale, Melissa McHale, would you please introduce yourself?
Hi, I'm Melissa McHale. I'm currently finishing my fellowship, and I'm specializing in endometriosis excision, and I'll be the newest member, I think, of the PRM team, starting in Washington, D.C. in the Bethesda and Falls Church offices this summer.
Great. Okay, I'm going in. And Dr. Liu?
Hi, I'm Lora Liu. I am a part of the PRM team as well in New York City, New Jersey, doing endometriosis surgery. Happy to be here.
And thank you. And Dr. Iris Orbuch, how are you?
Hey,
We're,
how are you?
We're very pleased to have you here, the star of the show.
Yeah, it's great to be here. Sorry, my office is in disarray. We're in the middle of like moving things around. I'm just happy to be here amongst such amazing people. Hi to all my friends.
Great. Okay, so I'm going to open it up. If anyone has any questions, I would like you can unmute yourself and you can ask questions to the panel. We can start with that.
I was actually just diagnosed with endometriosis like 3 months ago, so I'm just kind of interested in learning more.
Okay.
I can start. Just when I see a patient that comes in with a new diagnosis of endometriosis, first of all, I tell them congratulations, because the advocacy to get to that point is really difficult. I mean, we saw in this movie that patients take years to get a diagnosis and go through multiple physicians and, well-trained doctors, but maybe they're not, well-versed in endometriosis. And so that's half the battle. First off is to get the diagnosis of endometriosis, to understand what's going on with your body. And then once you get there, advocating for yourself to try to find, treatments. And as we sort of see in this video and as we look on this panel, really a multidisciplinary approach to treatment, including, physiatry, physical therapy, surgical excision, kind of walking through these steps to see which one is best for you, when to start, which step first is sometimes difficult to traverse as you're walking through this immense amount of knowledge. But really the biggest thing is that you have a diagnosis and now you can start working towards the treatment with a multidisciplinary approach.
Thank you.
Great. Thank you. Any other questions for our panelists tonight, or?
Well, we have a lot of people on. I just have one suggestion. Maybe we could put them in the chat. But one question I think might be relevant to many people here is what is the average recovery time, or is there really even such a thing for this condition?
After the surgery, you mean?
Yes, after excision surgery.
I'll let one of the surgeons answer that one. Anyone? Dr.
Sure, I'll say something. I mean, what I usually tell my patients is, everyone recovers differently. Everyone comes into surgery at a different baseline. But the beauty of minimally invasive surgery or laparoscopy is that the recovery is much quicker than your conventional open surgery with a larger incision. So what I usually tell my patients is, the first 2 to 3 days after surgery are extremely tough. You're uncomfortable, you're gassy, you're bloated because of the gas that we use to distend your belly with up so we can see. But generally, most of the time, pain is pretty well controlled with Advil, Tylenol. Sometimes if you need something stronger, not a big deal. But generally, after the first 2 to 3 days, you start to feel better. By the end of the first week, you're about 60 to 70% back to normal. After the second week, you're about 70 to 80% back to normal. But again, everyone recovers at a different pace. Full recovery, though, can take 6 to 8 weeks, sometimes even longer. It can definitely, recovery can be helped along with physiatry, pelvic floor physical therapy. Surgeries, I tell my patients, surgery is actually the easiest part. It's the recovery afterwards, and it's not just you're not gonna hop off the OR table and be 100% pain-free. It's definitely a journey. It's a process, and I think as long as expectations are realistic, recovery can be, it can be definitely quickened with some extra help from other disciplines. But like I said, the first few weeks can be tough.
Just from a patient perspective, and Dr. Liu said that so well. The first time I went into excision surgery, I had this belief that I was going to be in and out, and I didn't give myself any kindness or grace about the healing process. And I went back to work 10 days after, and I was not ready. I was limping around work. I was in pain. And it was one of my friends who I met in the endo community online who said, you just had major surgery. Even though these incisions are small, what they did inside was big surgery. And you shouldn't expect yourself and have this expectation of being superhuman and expecting your body to heal so quickly. And going forward with my entire endo journey from that point on, I treated my body differently. Just realizing that we all heal at a different pace, but do not expect your body to do miraculous things like heal in 10 days after also living with a disease that's kind of wreaked havoc on all different organs and muscles and tissues in that short amount of time. So just from my experience, just give yourself a little bit of extra time and don't put yourself in a competition in healing.
Can I add to that also? I love what you said. And I think I always tell my patients not to compare their healing post-surgery to anyone else's, because we all heal at our own rate. And our central nervous systems also all respond differently. And I think it also depends on how many pain generators we have going into surgery that really predicts, in my experience, how people's post-operative recovery goes. And I always let them know to set their expectations that just the physiology of healing, I think, is roughly at 6 weeks, you're 60% healed, and at 3 months, one is full healed, whether you're skateboarding and fall and skin your knee or you have major surgery. So to be kind to oneself and to give yourself the time. But I do think the more work people do up front with the multidisciplinary approach, pelvic floor PT, physiatry stuff, down regulating the central nervous system, identifying all the generators. The more you do work up front, integrative nutrition being so huge, getting the gut functioning, then do a good surgery. I think with all of that up front, it makes for the healing much quicker.
Yeah, I want to thank you, Dr. Orbuch, because I completely agree. And it's funny, in the world of, I'm a rehab doctor, and in the world of rehab, we do this quite often for if someone's having a hip surgery, a spine surgery. It's pretty common. I think in the world of endo, it's a new concept for a lot of people. But yeah, we are trying to get patients to really do what we call prehabilitation before surgery, to really set them up so that when they have their surgery, they bounce back faster, and hopefully don't require either any opioids at all or minimal amounts, and they're back faster than they would have been. So in an ideal world, I completely agree. It's best to get you prepared.
Can I want to give another patient input on this. I think it's really important to discuss the fact that there are a lot of barriers there that patients going into surgery may be facing. Do I have feedback?
Just for a second. Yeah.
Okay, is it gone?
Yes, it's getting better.
Okay. I say that because I'm coming on like 6 years out from my surgery. I don't know why there's such horrible back pain.
I haven't noticed that Rachael's iPhone is talking, whoever Rachael may be.
Okay, I see that popping up too. Okay. The reason I want to say this is so important because when I first came out of it and I was feeling so great and I was excited and patient advocacy, I was like, yeah, do all these things that I did. And this is why I was successful. And then the more patients I help and the more patients I work with over the years, I realized there are so many barriers that they face. So like I was an individual that was able to get super fit and I was so healthy and all these things. And I had great, surgical outcomes at first, but then I'm talking to individuals that are bedbound, right? They're really sick. They can't just like go spend the money on a nice gym with a personal trainer like I could. So it's like, I try to make sure patients that are new to this, or, you know, they're going into a surgery, I don't ever want them to get on social media and feel guilty that they're not doing this like perfect prehab. And I just try to tell them, you know, do the best you can. Let's get some movement in, do whatever you can do to like make sure that you feel like your body is in a place where it's going to best be able to recover from surgery. But there's a whole emotional component to it where I meet a lot of patients that go into it and they're like, I didn't do a good enough job beforehand. Is that why I'm not feeling better yet? I'm like, no, that's not it at all. You need to have a lot more grace with yourself. And so I really like to point that out. And I also like to point out to patients that excision surgery isn't just excision surgery. It's going to depend on your surgeon so much. And it's also going to depend on where you had endometriosis removed. You know, did you have an endometrioma that was excised? Because that's going to cause different recovery process than if you didn't have an endometrioma. There's just so many factors like bowel endometriosis being removed. Did you have a concurrent hysterectomy for adenomyosis? Because then your recovery is completely different at that point. So when people come to my DMs or they're calling me and they're like, I'm 6 months post-op, why am I not better? I'm like, well, let's take a step back and let's look at all of these things that you had done. And as your patient advocate, I'm going to lay everything out, you know, with different providers that you may want to start seeing at this point.
I love it. The theme of the night is be kind to yourself, and every case is definitely individualized and tailored and different. I'm going to answer some of these questions. So Annie Smith, I am 50 years old and just had a third surgery that resulted in a total hysterectomy. Now that I see this movie, I am sure I only had ablations. Can my endo return with a total hysterectomy? Is her question. Okay, Dr. McHale, do you want to take that one?
Sure. I think obviously it's really hard to say to speak to a surgery where you weren't there, of course. You know, I can't say with certainty what happened, but in that case, my worry would be more that the endometriosis is still there, rather than that it would necessarily, you know, regrow or come back. The analogy people use a lot of the time is if you think about, you know, a dandelion, if you just take off the top of the dandelion, the whole root system is still there. The majority of the plant is below the surface and you don't see it. So unfortunately, certainly we do see it happen that when someone has an ablation surgery, the majority of the endo that's causing their symptoms is still in place. And so often patients will have a recurrence of symptoms after the sort of initial shock to the system does happen with ablation surgery.
Thank you. Okay, so Helen Graham asked, what do you recommend excision surgery? If someone is still experiencing pain, how often should someone be returning for excision surgery? Any volunteers for that one?
I don't mind speaking on this. And this is a tough, you guys are asking some tough questions because there's not an absolute answer because everyone is a little different. But an excision surgery, ideally, if you are very thorough and you try to get wide margins around lesions, ideally you wouldn't continue to have surgeries. We don't have great literature, but our literature shows that, 15 to 20% recurrence at 5 years. And there's a lot of factors that go into this as far as recurrence of endometriosis, how much was excised, what stage you are when you have your excision surgery. But ideally, you would have one thorough excision surgery and then use this, multidisciplinary approach to kind of retrain the brain and your muscles and your nerves to have a better quality of life using, PT and physiatry. Occasionally, we do go back to surgery, and sometimes there is endometriosis, and we're still learning more about it as, to why that happens. Was it, fault of the surgeon, not getting wide enough margins? Was there microscopic disease that you couldn't see? Are there cells that are still, moving in the pelvis? But there's a lot of different moving parts to that question, I guess. But if you're still experiencing pain, especially immediately after surgery, if you know you had an excision with an excision surgeon, I would start leaning towards your other avenues of management, including, PT and physiatry, to kind of help guide you into what systems are still hurting, what is not improved, what is improved, and kind of work towards the areas that need help.
Yeah, and I'll piggyback on that. Is at Pelvic Rehabilitation Medicine, that is probably the most common patient we would see. And we are lucky enough to work with the excellent excision surgeons on this panel. So a lot of it is just explaining to them that the endometriosis was properly removed. However, you've been living with this for quite some time, and the inflammation around your nerves has changed the way your nerves actually work. And quite often you have chronic guarding because of the symptoms of endo in your pelvic floor, which are muscles. So it's fairly normal and it's okay. And then once we downregulate the nerve inflammation and the pelvic floor muscles, they quite often start to feel better. We have office-based procedures, pelvic floor physical therapy, as we had said, some potential suppositories or oral medications, and sometimes behavioral health and integrative nutrition. But quite often it's okay. It's a lot of, you're going to be fine. This happens quite often. So that's what we often see, and don't stress. We're happy to kind of help, but it is challenging once the endo is removed. Your nerves and muscles don't just bounce back right away because they've been under this inflammation and stressors for a long time. So they need to be rehabilitated.
Dr. Shrikhande, I totally agree. And that's why I tell my patients too. I say, I can remove 100% of your endometriosis, but you've been in pain for 15, 20, 30 years. A 2 or 3 hour surgery of a thorough excision of endometriosis is not going to, it's not going to take 100% of your pain away. I hope it does, but it may only improve your pain 10%. It may improve your pain 50%. It may improve your pain 99%. That's what I'm hoping. I hope this surgery will take 99% of your pain away. But the reality of it is most of the time it doesn't, because you've been in chronic pain for 15, 20 years because of this disease. It's not going to magically go away. And so it's very important for I think surgeons to tell their patient, set realistic expectations that this is a journey. And again, what Dr. Shrikhande was saying, we have, there's so, and Dr. Orbuch and everyone else on this panel just understands that there's so many different pain generators. Endometriosis is definitely one of them. We eliminate that, and then there's still a lot of work that has to be done. And hopefully we can get you to an 80% pain-free life, and 100% pain-free life. But it's impossible to predict how people are going to respond to surgery.
And I love that. And as someone on the non-operative side, though, it's so beautiful to see once you all remove the endometriosis lesions, how your muscles release, your nerves, they stop fighting us, and they stop being so inflamed, and they stop being so irritated all the time, because the nerves are what cause pain, and your nerve causes pain, right? So for us, it's really nice to see post-op that it's, wow, okay, we can really get things to downregulate and relax.
Can I add on to that as well? I think it's interesting to see outcomes now, because I'm doing things so differently in the last 8 or 10 years compared to, let's say, the first 8 or 10 years, coming out of training. At that time, I was operating, and then I realizing that there's all these coexisting conditions and these generators. Now I do it totally backwards. And I explain to patients that endo's like a domino. It's the first domino in a game of dominoes. And because of the diagnostic delay, most people have the next domino, tight muscles. So the endo knocks down that one. And because of the inflammatory effect and the interleukins and all of these endo implants, it wreaks havoc on the gut. And they often develop leaky gut or SIBO, small intestinal bacterial overgrowth. So that knocks that domino down. Then, there's the trauma and the depression and the anxiety from the years and seeing 8 physicians over a decade. And then there's all these other pain generators like central sensitization. So I work totally backwards now, meaning I try to get the ladder dominoes to get fixed before I operate on anyone. And what's so fascinating is often patients say, before I even touch them with endosurgery, because we're working a lot on the front end now, that their overall time to getting better is actually much shorter, even though the front end, there's more time before I operate. And they're often minimum 30% better by identifying the generators and then treating each one. So very often they're 70% better before I operate on them. And then I go in and operate and they continue that. And then I'm finding the patients are taking on average of 0 to 2 narcotics in my practice over the last like 8 years. There's outliers everywhere, but I think treating the central nervous system and central sensitization and all of those things, there's so much medical trauma too, which I love to talk about, and really talking about that and working through that before I take someone back to a hospital setting where there was trauma, had they had multiple ablations. And my outcomes are so different now. Maybe I'm a better surgeon almost 20 years in than I was, let's say 10 years ago. But I think a lot of it is actually down regulating the central nervous system. And I think the central nervous system and identifying the generators, I can talk about this till I'm like, blue in the face, but I think that honestly is the key to not having that question happen and setting expectations for patients. And I just really think that's the key that people aren't talking about when it comes to endosurgery. And I think Lori said it perfectly, like you had 15 years of pain, I'm doing a 3-hour surgery, but there's all of those other things that, had been going on for, you're saying they had 15 years of pain, but most people are born with endo. So it's a lot more than the 15 years of symptomatic pain because the inflammatory effect had been there since birth too. So it's just my 2 cents.
I love it how you described it, because when I say prehab, I think that is what I'm saying. It's identifying the pain generators, down regulating them, treating the central nervous system, any comorbidities such as inflammation in the gut, SIBO, with behavioral health as well, is what I mean by prehab. And that's well stated. And thank you.
Can I throw in one more thing about that? Because down regulating depression or dealing with the depression and the anxiety, because the more someone's depressed or anxious or has little t traumas or big T traumas or PTSD or OCD, what's happening is their gut motility is slowed down because they're in a sympathetic overdrive state. So we can treat SIBO with a 2-week course of antibiotic, but if we don't do modifications within ourselves, then the gut motility is going to be slowed down. They're just going to have recurrent SIBO over and over again. So it's like there's whole lifestyle and there's so much more to it than just like a quick fix. I think the prehab is really like the key to overall well-being and like really living one's life to the fullest.
And I think another, just to sort of add on to that, I totally agree about the importance of behavioral health. And I think one of the women in the film talked about how endometriosis had really broken down all of her coping mechanisms. And I think it's really important to acknowledge that and recognize that a patient, you don't have to have depression or PTSD, many people do, but endometriosis in itself is so stressful and having surgery is so stressful. And there's so much, pressure that we put into this because it's so difficult to get good treatment. And I think that talking to someone who specializes in behavioral health for people with chronic illnesses, I think is really essential to good, to getting optimal outcomes, because it helps people really sort of get in the right mindset, sort of all of the other diagnoses and things aside. I think it's just an integral part of endo treatment.
This is a line that we have to be really careful with because we're so often told, a lot of the pain is in our head, right? So I toe this line very carefully. So I'm diagnosed bipolar and I'm an alcoholic. So for me, leading into all of this, that's what everybody looked at, right? It wasn't the endometriosis. It was, well, you need to get this other stuff in your life under control. Sure, I drank mostly to deal with my endometriosis pain. People are like, alcohol makes it worse. And I said, not if you drink it all the time, right? Like not if you're always drunk, you don't feel it. So that's how I managed my pain. But I don't think that my pain didn't get better just because I quit drinking and I addressed that. And my pain didn't get better just because proper therapy and I'm properly medicated, right? So it's like I got all of those ducks in a row and I got in recovery, and I actually thought, okay, this is it. This is when I was going through like I'm going to treat my endo naturally thing. I got this, but then it was progressive, right? So the bowel symptoms were getting worse. I was like, well, how? I'm eating so good now. Everything's great. I'm working with a naturopathic doctor. Things just were getting worse and worse and worse. And then, that's when I was like, okay, finally, when I had my last emergency room visit, I was like, I've done everything else I thought I possibly could. And the disease is still wreaking havoc on my body. And that's when I had surgery. And lo and behold, once my bowel endo was removed, I can magically eat Taco Bell again. Like, I'm not saying everybody needs to go out and do that, but I was just like, oh, that was the actual underlying problem. I thought I had done all this healing, but it was just a really important moment in my life to realize that this is a disease that does need to be surgically removed before my body could then calm down, and then I could begin the healing process.
Love it. To piggyback on that, I think a good question is, have you ever been in a position in which a doctor or a person of authority didn't believe you?
Yes, 100%. I think we all could probably say that. So, but I wanted to say something real quick about, I don't know which doctor was talking before about the work to do before surgery. Because it just like blew my mind, like thinking of it that way. Because I had a partial hysterectomy in 2016. They said I had endometriosis. They got out as much as they could. And my doctor was very much like, it'll be fine. It'll be fine. It'll be fine. Don't worry about it. It'll be fine. And 2 years ago, I had horrible pelvic pain and back pain and went back to the same doctor and knew something was wrong. So I went to Chicago to the Pelvic Rehabilitation Center. So shout out to Dr. Natarajan for helping. To make a long story short, I ended up getting a surgery going into it thinking, okay, I might have, I have this hard mass on my right ovary, but it'll probably be all right. And I had like a 5-hour surgery. It was all in my digestive tract. It was just a mess. And that was a year and like 14 or 15 months ago. And I've been in pelvic floor therapy for basically a year straight. And I'm still like, I'm so much better, but I'm still like so beat up because my body, I feel like, was in so much chronic pain for so long that I'm kind of like, again, I'm so much better, but I'm still struggling in all kinds of ways. But to segue back to your original question, I had a doctor tell me, a surgeon that I saw like locally, where I live before I found a much better surgeon that looked at me, even though they already found endometriosis, that looked at me after examining me and said, you don't have endometriosis, your pelvic floor isn't tight. And I was like, I've been using Valium suppositories for the last 2 months. And she was like, you probably have a back or hip injury, and basically sent me on my way. Even though in my chart, they found it in 2016 and I was diagnosed with it, and she still wouldn't listen to me. So, it took me like a year to find a good surgeon. And so, yeah, there's, the shortened version of the story. But again, back to what the one doctor was saying, or the surgeon was saying, that I do feel like if we went into the surgery with me doing some work beforehand and working on different stuff, maybe my recovery now wouldn't be so bad. And I did change like diet stuff and went gluten-free a long time ago and not eating red meat, and did a lot of stuff for my digestive tract, just because I didn't know what else to do. I didn't necessarily know it was endometriosis at that time. But so there's my 2 cents. I don't know if any of that made sense.
Can I piggyback onto that too?
Mhm.
Like the way that I explain it to my patients, I'm an athlete and like a triathlete. And I say like surgery is like the race, whether you're doing a marathon or whatever. You're not going to show up to race day with a pair of Vans and like having been drinking all night long and poor nutrition and without a water bottle. No, you're going to like train for the race. You're going to have great nutrition. You're going to have a great night's sleep. You're going to have your electrolytes optimized. You're going to have a plan for the race and post race, whether you're going to be in an ice bath after, whatever it is. And
Right.
that's the same approach I take when it comes to my patients in surgery. you're not going to show up. You show up to surgery so exhausted, beaten down, and sympathetic overdrive, like literally feeling like a bear is chasing you. It's going to be really hard for your body to heal. So, you know, it's like night and day outcome differences that I'm having in the second 10 years of doing this than I did in the first 10 years. It's like, it's mind blowing crazy with the prehab.
Right. And I had some of the prehab. I mean, again, I went gluten-free. I stopped drinking alcohol probably a couple of years before the surgery. Like, so I did have, you know, more awareness in my body with, you know, healthier stuff like digestive wise, but the rest of it, like, I just had no idea, and how messed up my muscles, and my pelvic floor was just like a wreck. I mean, it was, you know, right when I was able to somewhat start moving around again after 6 weeks, my pelvic floor started spasming, and it was just miserable, you know, and then we kind of got that under control in pelvic floor therapy, but now I'm dealing with like still like low back pain and pelvic pain, and I'm a lot better, but for as long as it's been since my surgery, I'm still struggling, you know, so much. And I put in the comment, I don't know if anybody's seen it, but I was wondering if there's a link between like estrogen driven breast cancer, the DCIS, and endometriosis, because 6 months after my endometriosis surgery, my doctor tested my hormone levels going into my endometriosis surgery, and my estrogen was like over double what it was supposed to be. So she was like, right when you're recovered enough, you have to go get a mammogram. And I did. And to make a long story short, I ended up having breast cancer. So I had to get a double mastectomy. So I always have wondered if there's a link between like estrogen being so high with endometriosis and getting the estrogen driven breast cancer.
I think that'd be a great research study. I mean, obviously, you know, we talked about in the video how endometriosis is kind of the stepchild when it comes to pelvic pain. Most of our literature that we read off of is from the fertility literature, because they have a lot more money, they have a lot more resources to do their research. There are some good studies kind of coming through the pipelines that I'm excited about, but I think that would be something very interesting to look at, and probably not that difficult if you could do a retrospective cohort. But yeah, we are really looking forward to, you know, doing more research with endometriosis and endometriosis patients, because that's how we see change. That's how we see change in how doctors are trained in OBGYN. That's how we see changes in more endometriosis surgeons, you know, excision specialists being available for patients. And that's how we see change with, you know, all of the medical community understanding kind of what we're treating, kind of our uphill battle.
Right. No, it's just something I've been thinking about, because that was like the first thing my surgeon in Arlington Heights, Dr. Yankee, the first thing she did was make sure that the hard mass on my ovary wasn't ovarian cancer. And she tested my hormone levels, and it threw up the red flag for breast cancer. And she said, it's just protocol there. And I'm so thankful for her, because I don't have a family history of it. And was 43 then. I mean, I'm 44 now. So it just got me thinking that I feel like women that have endometriosis, I mean, maybe their hormone levels should always be checked, because if it wasn't for this doctor checking my hormone levels, even if I would have had a mammogram, they would have been like, you're young, it's fine, you don't have a family history, because it was, you know, calcifications, like the beginning stages. So it's just something that I've been, you know, wondering about, you know, going through this whole health journey, and wondering if there's been other links with other women with it.
I want to say, based on the published literature that we currently have, we don't have an increased risk that is notable greater than just average lifetime risk. So that means somebody's risk of developing a specific type of cancer increases just by getting older, right? So just as the cells have a more difficult time properly replicating, it just occurs. Our bodies just get worse at doing that as we age. So you get a natural increased risk of cancer that way. When we look at literature trying to see, is there a potential link? The only link that we've maybe seen with endometriosis has been slight increase with ovarian cancer, but when you compare it statistically, it's not greater risk than normal lifetime risk. And also, I like to remind patients that while endometriosis lesions themselves do react to estrogen fluctuations, they could generate their own estrogen. And it's important to note that there is no published data stating that endometriosis patients have a greater amount of estrogen circulating in their body. Because a lot of people want to try to talk about estrogen dominance, but the issue with that is that really just has to do with a ratio of estrogen to other hormones in your body. And then we don't actually see an increase in endometriosis patients having more estrogen. But I think is there, we think that, a lot of endometriosis results from epigenetic factors, and so does cancer, right? So is there maybe a genetic underlying propensity that we may have? Maybe. I mean, obviously we need more research on that, but I think, like you were saying anyway, it's important to always, keep ovarian cancer and breast cancer on your mind, no matter what, whether you have endometriosis or not. I think that's important.
Yeah.
Can I make a comment about that?
Yeah.
Just, I think, endometriosis, we don't know that we say 10%-ish, and breast cancer, 1 in 8 will develop breast cancer in our lifetime. So they're just two common things that may be coexisting. But I do want to make a comment about the ovarian cancer. Endometriosis and endometrioma does increase the risk of ovarian cancer. Especially, we know that there's a 2 to 3-fold increased risk in ovarian cancer. So I think and that's well-published data. I think Farnajat did a lot of that data, and there's some other authors. So I do think it's important for patients who are having surgery or who have a family history also to have that evaluated and to have that checked.
Yeah, I think
Dr. Orbuch, honestly, was so striking in the film, in Shannon's film, your comment about the NIH's dedicated research, 8 billion to diabetes, and then significantly under 100 million to endometriosis. I mean, the disparity is striking, and clearly that's hopefully what Shannon's amazing approach will achieve, of really fighting Congress to dedicate more research dollars to a poorly understood disease process.
Yeah, I think they heard us in Washington, right, Shannon?
Yeah, I think they heard us. Yes.
Yes.
And it's really not fighting Congress. It's really just showing them a reason. It's just like, this is the story and this is why you should care about it. And, they will, if you make it personal to them and show them there's a reason, for increased research funding. And I had a call, like I think I mentioned last weekend, like with the director of the NIH, NICHD last week. And she just said, this is what I need. Like literally boom, 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 to allocate earmarked funding for endometriosis research that does not get lost in appropriations, which is what happened with the other earmark that we were hoping would get, over 20 million. But it just got a little bit lost, and that happens. There are a lot of conditions that are jockeying for that NIH funding. So we just need the earmark, and we have the language, and we have how to make it happen. So now it's just next steps, and just motivating Congress and having really great legislative partners that are motivated to stick their necks out and say, this is what we need to allocate to. But yeah, we're on our way.
Thank you. Thank you, Shannon, for the update and for all your hard work with connecting the dots, I think is a nice way to say it, right? And educating.
Yeah. And working together, I mean, we have to work together. This is a disease state that's been lacking in real, meaningful progress for decades because everybody's in different camps, and there's a lot of crosstalk, and I'm just frankly tired of it all. I think I have to work together and focus on what we have in common, because at the end of the day, that's the most important thing.
That's great. I mean, Shannon, would you be able to comment on kind of your biggest challenges and your biggest kind of wins recently of really being able to move the needle forward in the world? Clearly you're really making an impact outside of America, and connecting. So if there's any comments, we would love to hear it.
Yeah, of course. We screened around the world in the past 10 months, after we opened in New York at MoMA. And then we did an amazing screening, for example, in France, and have had a really amazing response there. And then, we screened in Israel recently, in Dubai. So really bringing the film into different nuanced conversations in different cultures and understanding what their hurdles are. Like in Dubai, for example, I learned that people who have endometriosis won't even tell their immediate family members, like their mother or their sister. There's that much of a stringent taboo that they won't even do that. So how do we actually, get to those people and help those people and educate them when there's such an enormous taboo that they won't even tell, their closest family member? So that's this whole, host of issues to get past. And, we're trying to do that. Whereas in other, in obviously first world countries, it's more into legislation and a national action plan and all of these amazing things, but there's not just one way to approach them all. And it takes a robust effort, and it's going to take all of us.
Thank you.
Challenges, but things that there's a lot of possibilities too. At least we're seeing them, and they're coming into focus, sharp focus around the world, and that helps with getting the word out about the disease and this human way to create this human connection. I always say, Dr. Orbuch's heard me say it a lot of times, if we change hearts and minds, we can change policy. So that's what we're trying to do.
Yeah, I must say it's amazing to see. I remember Dr. Orbuch and you, Shannon, were collaborating. Gosh, it must be 8-10 years ago now. And I think it was more of an idea, and just wow, like the impact you've been able to make, and you really are opening up hearts and minds. So it's really great to see. And thank you. Thank you for all the work.
And something to go back to by the way, when the question was, has anyone not been believed? I'm looking at a gallery view of like 20 people. Everybody smiled at the same time, because everybody has not been believed. It was kind of this wave of response. So, what does that say? And I know Dr. Orbuch has talked about this as an endometriosis specialist, and I don't know if you'd be willing to share that as a specialist, still not being believed.
Yeah, yeah, no, I love that you're bringing that up, Shannon. I'm like an open book if anyone knows me. And I think it's important for advocacy is sharing my experience. I had pain for 16 years and was told I'm manifesting my patient's pain. And I, was gaslit, and I believed someone else, like a man who was telling me that, when this is what I do for a living. And my daughter, when she was 9, I'm like, she's got endo. And all the doctors were like, no, she doesn't. It's because you specialize in this. You think your daughter has endo. And like, it just took years to fight through if it was a mom bringing that 9-year-old to me, I would have been like, yeah, she totally has endo. So I myself, like literally, right, isn't it like the shoemaker has the worst shoes? Or isn't there some saying like that? So yeah, I think more than anything, we have to trust. And I don't remember which of the comments someone said they went to multiple doctors, or their doctor said with your operative report that they still didn't identify endo. Like they're like, no, that's not contributing to your pain. Like we just have to believe ourselves and just keep pushing in the same way that like Shannon had an idea, and she just kept at it, and now there's a train. And it's either join it or not, like we just have to keep trusting and believing, raising awareness, sharing our stories, and it just will go viral.
Can I add something to what Dr. Orbuch just said? My name is Rachael Lopez. I live in Dallas. I don't know if Dr. Haverland, if you remember me, but I saw you late last year. And on the other side, because all of us have had that moment where we haven't been believed. And I just want to express that when I saw Dr. Haverland, that was the first time for me that a doctor believed me. And I almost like gaslit myself going back, because I was like, why did she, like something felt off of like, why did she believe me so easily? Like like that was too easy. Like she didn't question me, she didn't argue with me, she didn't like, and it made me question, like, wait, let me look into the, and I just have to say that I even called a friend who's on this call, and she's like, it's because you've never experienced that. It's like, that's what it's supposed to be. You've been gaslit for years and years and years, that it almost made me think like, wait, why was that so easy? I had never experienced that. And so I just want to thank, all the specialists that are on here, just for even that, just for listening and for believing us that, for some of us, we really have gone through all this journey and haven't had that. And I'm just so grateful for this community. And it's so important to have these advocates. Katie, I didn't even know that there was such thing as like advocates like you. And so I just have to say that from the other side of it, it's a amazing experience to have somebody believe you.
I totally agree with that too. Dr. Natarajan at the Chicago location was the first person to listen to me. And I also had a similar experience that you just were talking about, like kind of like questioning myself, but also being like, maybe it's not that bad. Like, maybe it is still in my head, like, so I get it. So I appreciate all you guys for all this research and what you're doing, because it's been a life changer. So thank you.
I just want to say that when you finally find that doctor who believes you, that's honestly one of the first steps to that healing process as well, right? So even though I'm so far on the other side and I help patients go to these appointments, I still have so much, and even through all the therapy I've been through, I still have my own hangups with going to an OBGYN because of the repeated essential torment that every time I went in there, it was all on me. I was making it up. It was not believable, right? And I just feel like I just like patients to know that that feeling deep inside is so real. And that's another reason why I like to go with patients to appointments, so that if they feel like they're not being heard or they're being gaslit, I'm in that room to say, no, right? That's not right. And I like to hold their hand and say, let's go find you another opinion, right? Because I'm tired of seeing patients being denied that care. And I'm tired of seeing people continue to get treated the way I was treated 15 years ago. Like, how is it still happening?
Yeah, I agree. Even when my patients come in for their pre-op visits, I go through the risks of surgery with them, bleeding, infection, injury to surrounding structures. And they listen to me and then they say, okay, but what if you don't find anything? Like, it's always in the back of their mind, even right before they go into surgery. It's because they've unfortunately had these experiences. And, like Dr. Orbuch was saying, we even have these experiences with other physicians that haven't necessarily looked into the research or not a part of our field or may not, have the same experiences or training that we do. And so really just advocating for your patients, telling them to trust themselves. I mean, I rarely go into surgery and don't find anything, but because of you, people like Katie or other patients, they just haven't been heard. And so their self-esteem, their belief in their own symptoms, it's pretty unbelievable. So advocating for yourself, I think, is the hardest part. And being here, listening, watching this video, finding doctors that listen to you, that's a huge step in finding treatment and finding a better quality of life, just like Rosie. And I do remember you, of course I do. As soon as you came up, I saw your face. But anyways, good to see everyone.
Rachel, I totally agree. I think the two most common questions that I get together are, am I going to need a colostomy? And what if you don't find anything? And it's amazing to me that the dissonance is like, your symptoms are so bad that we're talking that you're asking me if you might need a colostomy, right? Like, this is dominating your life. And you're still questioning in your mind, like, like whether or not you have it. And so it always really blows my mind, like you were saying, that people, you know, women need to be told to trust themselves. Patients with endometriosis need to be told to really trust their symptoms. And I had a really funny experience with actually a rep for a birth control company who had previously interviewed to be a rep for my Fimbri. And she spends all day in OBGYN's offices. And then, you know, of course, as we're chatting, her periods come up and I find out she misses work for her periods. And I was the first person to say to her, it really sounds like you have endometriosis. Like, you're in the bathroom all the time. You can't go to work on your period. Like, has anyone ever talked to you about this? And she was like, no, but I guess I've kind of wondered, but I figured since it never came up, it couldn't be possible. It's like people who work in this field still question themselves. And so it's definitely have the same experience you do, Rachael.
All right, this is great, guys. The questions are piling up, and now I have 41 new questions, but I'll start at the top. So what questions should we ask our doctors to ascertain if they're true excision specialists?
Can I start this one off?
Sure.
Thank you. I spend a lot of time when I'm working with patients, focusing, you know, on what questions they should ask when they decide to finally go find their doctor. And I typically, you know, of course, so say you've already gone through, you have the basic of, you know, okay, I think I finally found this is, you know, narrowed it down to endometriosis surgeons. You know, I tell people that it's going to vary a little bit on what their symptoms are like. And also, you know, anybody can call themselves an endometriosis surgeon, right? There's no like official title that has any sort of like qualifications behind that. So it's really on the patient to make sure they're vetting that surgeon themselves. And so one of the first things I say to do, you know, is just openly discuss with that surgeon how frequently they're operating, right? Like, so are you operating only a couple times a month on endo patients, or are you actually doing this day in, day out? And then what kind of complex cases are you doing? And so that way the patient can get a feel for it. Okay, so this is what they really dedicated their time to. I can trust that I'm going to be in good hands with them. And then, you know, then I say, you know, let's talk about the other basics. Like, are you doing all excision versus the ablation or the cauterization? Are there places that you don't feel safe removing endometriosis from? You know, in that case, do you, you know, and if that comes up, but you know, are you willing as the patient to be okay with them cauterizing those areas? Like, I mean, that comes down to patient. Of an ideal world, no, but not all patients can access all perfect surgeons. So that, you know, that becomes like a pros and cons list for that patient. But that, and then, I mean, I'm always like, make sure you ask, you know, do they believe in like hormone suppression after surgery? You know, is that something that you'd even want to be around, like deal with, you know, the facts behind that. So I'm really big on noting the surgeon's approach, you know, to follow-up care. You know, green flags for me are, okay, let's focus on physical therapy after, let's see what other, you know, pain generators we can address after surgery. I feel like those are really great green flags. And another thing that I feel is really important also is just like how you feel with the surgeon. So my surgeon was really big on like my gut feeling almost with them. He told me, he's like, I don't want you going under anesthesia, having, you know, being nervous about me being your surgeon. He said, I want us to be on the same page and I want you to be really comfortable with where we're going with this. So, you know, those are just some of the questions that I like to start off with.
Great. Thank you. Okay, the next question is, I just had surgery last September for my endo. My bowel was attached to my uterus. The IUD, the Mirena, did not do well with my body. My belly is still bloated. I'm currently on metformin and I still can't lose weight. Also, my thyroid is enlarged. I've had thyroid biopsies, which came back benign, but no matter what I do, I can't lose weight. Is there certain questions I should ask my daughter about weight gain with endo? Is there a correlation with endometriosis and the thyroid? There's so much misinformation about diet and how to work out, etc. I'll start that one off with the thyroid. With endometriosis, there are kind of certain red flags that we all kind of look for. And one of them is other autoimmune diseases. And of the thyroid is a fairly common one, Hashimoto's thyroiditis. So I would say you would want to see an endocrinologist as well to get evaluated and see how your thyroid is doing. That would be potential correlation with endometriosis and the thyroid, is through that autoimmune connection. I don't know if anyone else wants to answer about the weight correlation.
I think that the weight is really difficult because everybody's body responds so differently. But we know that endometriosis is an autoimmune process. You do have this inflammation in your body, which certainly leads to fluid retention and can make it much more difficult for weight loss, weight gain, maybe even, decrease your metabolism. I mean, certainly from, being more sedentary because you don't feel good, or, inability to exercise or get out because of the pain aspect. And so that can be really difficult. One thing that I do like about PRM is having the nutritionist, and there's not a diet that works best for everybody. Not everybody can go gluten-free and they're going to be perfect, or dairy-free and their symptoms are all going to resolve. And so that's why it's sort of tailored to each specific person, because each person, reacts to foods differently. Different foods may cause them to bloat or cause them to have, more likely to have a flare. And so you're right, there is a lot of misinformation, about diet, and I'm certainly not an expert in this, but this is why we have, people, our nutritionists and PRM that can talk with patients about different options. But this is, I'm just going to tell, it doesn't say who this patient is or person is, but certainly you're not alone. This is very common with endometriosis. The bloat is very common. The inflammation, it can be related to bowel, it may be related to endo. It depends on, if you had a good excision surgery, or what kind of endometriosis surgery you had, may play a role as well.
Thank you. Thank you. And unfortunately, we are running out of time, and there's so many questions. I mean, one general question I'm seeing repeated over and over is, if you do have surgery and you do have endobelly or persistent pain or pelvic floor dysfunction post-op, yes, it's very common. It can be treated. I've seen that throughout many of the questions. So that can happen, as we discussed, and it is kind of part of the process, and then you just get that, you can get that treated post-operatively. One last question, and I think we have to wrap it up. Can someone speak more on microscopic endo? How can it be removed if it's not seen during excision surgery?
I'm happy to chat on that. Sorry, I had to eat my lunch, which I haven't eaten, and it's like dinner time. I think you can see it often microscopic endo because there's usually increased vascularity leading to those areas in the peritoneum or wherever the endo is. And you can use different dyes like ICG and different to look at depending what platform you're using. But I think microscopic endo, lots of times people are calling it microscopic, but if you know the difference in the peritoneal appearances, I think it can be picked up by looking at the vascular patterns in that area. And I think there's also high yield areas like the cul-de-sac and rectovaginal septum, like, if you're actually, Lora, it was your dad who taught me this when I was working with him. He told me how he took care of this mother and she had tons of endo. And I don't know at what point in his career this was. And then she brought her daughter, who was a teenager. And your dad was telling me that his patient said about her daughter, that's exactly how I started. And I think it was one of the earlier patients your dad actually operated on, a teenager. So your dad took her to the OR. Who knows what the camera system must have been back then? It was like a Linvatec or something, who knows, horrible. And your dad said, I didn't see any endo, but I knew that where the high yield areas were in the cul-de-sac, uterosacral area, and microscopically it came back as endo. I thank your dad for so much. So much.
Yeah, he's okay.
But yeah, but I think if you usually there's hints when you're operating, and then I think as surgeons, we all know those high yield areas that we would excise, and and there's usually something there to hint that there's something beneath the surface, even like clear vesicles in the teens that you don't pick up until you bring the camera so close to those areas. So it's usually there. I think it's just not being picked up because the surgeons don't know the varying appearances of it. That's my personal thought.
As I want to say as a patient, that what you just heard is exactly what you want to hear your surgeon say when you're interviewing them. Like that is it right there. So if you're, going through those questions, Dr. Orbuch nailed it right there. Thank you so much for that.
All right. Well, thank you, everybody. I mean, I think that, it's great to see everybody participating and engaged. And thank you, Shannon, for all the amazing work you're doing with producing both Endo What and Below the Belt. And of course, Dr. Orbuch for being in the films and the panel here today. I know you all are very busy, and between helping patients and being patient advocates, it's impactful work that you all are doing, and we all appreciate it very much. So,
can I ask a question?
Mhm.
Is it normal when you have a hysterectomy for the doctor to actually endometriosis behind?
Mm.
So my doctor said that it would go away on its own, and she left it behind when she did the hysterectomy.
It's generally no is the answer to that. We would not expect it to go away on its own. That's sort of the myth that has been taught to so many OBGYNs for such a long time, is that you can remove a uterus and that's going to treat endometriosis. And that's not the case. And so unfortunately, it's not going to treat the endometriosis that remains.
So it's still basically there after a year.
Yes.
Okay. Thank you.
Yeah, I mean, it just goes to show a lot of, as the Shannon's movies have stated, really a lot of it is the education of both in the medical students, the residency, the fellowships. So I think that it is a disease we are still learning about, as we have stated, and we need more research, and also the training needs to catch up from starting with the med student, right? So. Great. All right, and thank you, everybody. I really appreciate it. And again, thank you, Shannon, for the film. And it was amazing and great questions. And panelists, thank you for your time and your impactful work.
Thank you. Thanks,
Have a great
everyone.
evening. Thanks, guys.
Thank you.